Evidence-informed policy networks, which we call a VIPNet for short, are doing many things to support evidence-informed policymaking. I would really zero in on 4 of them that I think are particularly innovative and likely to have high impact. So one would be producing evidence briefs for policy. We see ZAMFOR, the Zambian Forum for Health Research, producing these. We see a VIPNet Burkina Faso producing these. They start with a policy issue and try and understand what is the real problem or the causes of that problem. They then work through what do we know about 3 options for addressing that problem, and then they move on to implementation considerations. They put all the evidence in one place. They might involve 10, 20, 30 systematic reviews as well as local studies. Second innovation would be policy dialogues, informed by those briefs, but they're a chance to put the evidence alongside the tacit knowledge that people have built up and to consider that in the context of the institutional constraints they're dealing with in their country, the interest group pressures, the values, the donor and WHO inputs, and so on. The third innovation would be rapid response units, originally beginning in Uganda with the Regional East African Community Health Policy Initiative and now spreading to Burkina Faso, Cameroon, and other countries. Quite a revelation for policymakers now to be able to phone up and say, we just have 3 days to be prepared to brief the minister. Can you put together the best available evidence in that time period? And then the fourth would be clearinghouses, trying to find all the studies that have been conducted locally that are relevant to strengthening health systems or getting cost-effective programs, services, and drugs to people who need them, and have them all in one place so policymakers and stakeholders can find them efficiently. We've contributed to the efforts of the evidence-informed policy networks primarily through health systems evidence, and that in a couple of different ways, as well as through training. When it comes to health systems evidence, first we've made it available as a free public resource to help people find and use research evidence about strengthening health systems or getting cost-effective programs, services, and drugs to people efficiently, and we've done that in 7 languages: Arabic, Chinese, English, French, Portuguese, Russian, and Spanish. And we've done that with the help of many partners, including 3 WHO regional offices and headquarters. We've also added to health systems evidence an intergovernmental health systems documents portal. That means that anytime you search health systems evidence, you're also simultaneously searching any WHO documents that have to do with health systems. So if there's been a WHA resolution related to health systems, you can immediately pull that up, but also be prompted to say, hey, there's also systematic reviews on this topic, also economic evaluations, and these may have been published since that WHO guidance or resolution was developed. Third, we've integrated health systems evidence into the VIPNet virtual health library so that any people who are using that as a regular source of evidence, when they're searching the VIPNet VHL, they're also searching health systems evidence. So all of this is in service to making evidence much more readily available to policymakers, stakeholders, and the VIPNet teams that have supported them. The other thing that we do is we do a lot of training, typically a train-the-trainers approach, where we introduce people to a lot of these concepts about finding and using evidence efficiently, and then equip members of their local teams with the capacity to provide that training to policymakers and stakeholders in their country. We've benefited from these efforts in a lot of ways. I would single out 2 as being particularly important. So one is in the area of rapid response units. When we have watched the VIPNet teams in many countries around the world, but especially in Africa, the innovation that really took off with policymakers and stakeholders were rapid response units. We saw incredible interest in Uganda when it was set up by the Regional East African Community Health Policy Initiative. We see a significant emerging interest in Burkina Faso, Cameroon, and other countries that are now setting them up. So we here in Canada said, you know, this is what we need in our own country. So as of April the 1st, 2013, this year, we have introduced our own rapid response unit to help the governments in Canada who run health systems to be able to find and use evidence very efficiently, whether they need that response in 3 business days, 10 business days, or 30 business days. And we're modeling it very much on the innovation that we first saw that was originated at REACH Uganda. The other way that this has had a big impact on our thinking has been in terms of how we produce evidence briefs as an input into policy dialogues and how we actually convene the dialogues. So we had our own model for doing these, but it's through regular meetings with our partners in Africa, in Latin America, and the Caribbean, and in other regions, that we've come to see that we can continuously improve how we do things. So we're constantly watching the innovations happening in those other countries, and then when they seem appropriate for our context, we're embedding them in how we actually do things here. So it's been an incredible win-win situation. We'd like to think we put a few things on the table, but we certainly get a huge amount back in return. So it's been a really delightful opportunity to share experiences across countries. In this case, I think most of the transfer has gone from south to north.